Perfect, brilliant. So I will just go on to the next slide, which is just introducing ourselves. So I'm Glenda Beard, I'm a GP at White Ladies Road, and I'm also the clinical lead for cancer at our ICB. And Georgia, I will let you introduce yourself.
Hi everyone, I'm Georgia. I'm the primary care cancer facilitator for early diagnosis, working very closely with Glenda and with our colleague Lynn, who's also on the call. Lynn, do you want to introduce yourself?
Yeah, hi everyone. My name's Lynn. I'm the Learning Disability Screening Practitioner for BNSSG.
Perfect, thank you. So just moving on, why are we here today? Why are we running this webinar? Well, we are running this webinar because we know that there remain to be challenges around the completion of FIT for our patients, our population. We are currently running a project where we've got representation from every PCN across BNSSG called our sort of FIT task and finish group, looking at some of these challenges and trying to say, how are we going to improve this process for our patients and make sure we're using FIT in the most effective way and getting those results back in a timely fashion and minimising duplication of work. So every PCN that's taking part has been doing work around this, looking at FIT completion, safety netting, as well as ways to reduce health inequalities. And the session came back as part of this conversation. So actually, it would be really helpful to have an education session for everybody in the sort of practice team to really understand what FIT is and why it's important. And the key thing is that FIT is a marker for bowel cancer, a surrogate marker. So it doesn't mean having a positive FIT result means you have bowel cancer, but it means that the risk is much higher. So FIT is looking for blood in the poo, and it's often blood that you can't see, that's sort of mixed up within the poo. So people don't know that they're bleeding, but there is blood that's there. And that can come from a whole range of different things. So it can come from polyps that are little growths, like little skin tags within the bowel, that can go on to become cancer. It can come from cancers as well. It can also come from other sources within the gut. But the reason we're doing this FIT test is really to find those polyps, remove them, find those cancers and treat them and do that at an early point. Some delightful photos there for everybody. So the samples that we do in the community, we send them off to the lab and then they're analysed. There's the clever machines in the lab that do this to give us those results that come back through ICE to our practices, so we can decide whether we do need to investigate that person further, and if we do, on what sort of pathway we're going to do that, whether that might be the urgent suspected cancer pathway, for example, if that test is positive. We have this poster which we have been pushing out to primary care, so I'm hoping some of the people on the call will have seen this poster. And it's really because there's been quite a lot of confusion around this FIT, and that's because it is the same kit that is used in the National Bowel Cancer Screening Programme as it is that's used for symptomatic patients within primary care, and that means two things. It means that firstly, that the kit may be familiar to lots of people because they've done it before, but also that people can sometimes be falsely reassured by the FIT, having done a sort of screening FIT and it being negative, that they therefore don't need to worry about the symptoms, they don't need to present. And as clinicians, if we don't understand that the test is slightly different, then we could also be falsely reassured. And it's different insofar as the threshold for a positive test result is really different. So if you are a patient with symptoms and we send this kit off from primary care for patients, then for that test result to be positive, then the level of blood in the poo is 10, okay, so 10 micrograms per gram. However, as a screening test, the level of blood in the poo to get a positive result has to be over 120. That is changing. We're not going to need to worry about that today, but it is a really big difference. And even when it does change and come down a bit, it's still going to be a really big difference. So it's so important if people are symptomatic that we know that and we're not falsely reassured by the fact they've had a negative screening FIT. So hopefully that poster is out with practices, and you can also see that's flagged there that the FIT is the specific kit, and that's one of the challenges with our lab is they still receive lots of FIT requests with that blue lidded stool pot, which they can't use to process for a FIT. So this is just a slide with lots of data. We like to have a little bit of data, and it's part of this FIT task and finish group. And again, part of this importance of making sure we're all aware of the importance of FIT is that we know when we see patients with symptoms in primary care and we say, I'm not happy about your symptoms, I'm worried this could be something more significant, something more serious, we need to do this FIT test to understand what sort of investigations we need to do next. But we know that not all patients are equally likely to complete that FIT. And that adds sort of health challenges around health inequalities. So we know that men are less likely to return a fit. So even if I do my best persuasive conversation with them and really try and explain why this fit is really important and why it will help us to know whether they may or may not have cancer, they are still, less likely to return that kit and therefore not be investigated further potentially. We know older patients are more likely to return that kit, and there's probably a multitude of reasons behind that. We know that often younger patients think it's so unlikely to be anything serious. They present later with their symptoms because they're more likely to think, oh, it's IBS, or I've just changed my diet, or other reasons, whereas older patients are more likely to be worried about their symptoms and present with them. We know from a deprivation perspective that our patients living in the most deprived areas are much more likely to not return their fit kits than those in the least deprived areas. So that's a really significant, again, health inequality of something we're doing, a step we're adding to the pathway to investigating people's symptoms. That means they are more likely to have delays in knowing what happens. And we also see a change depending on patient ethnicity with that. So patients from Asian, Black, and mixed other ethnic groups are again less likely to return that fit. One of our practices shared at the last Fit Task and Finish group meeting that when they looked at the fit kits that hadn't been picked up, actually quite a lot of those were from sort of patients who are living in nursing homes. And that was again flagged to them. They said, what's our process around those patients? How are we making sure that the fit kits are getting out to them so these samples can be provided so we know what we need to do next? So there are health inequalities around fit completion, and therefore it's really important that we're aware of that so that we try to address that and make sure people are sort of followed up and safety netted as part of this process. If we look at bowel cancer screening, there's also health inequalities around that. So we know that the uptake varies by ethnicity, it varies by socioeconomic group. We know, again, it's lower for men. So the health inequalities that we see from a symptomatic fit are fairly similar to those that we're seeing as well for patients within bowel cancer screening. So I'm going to hand to Georgia, who is going to talk about the role of fit and bowel cancer screening. Okay, Georgia.
Thanks, Glenda. So in terms of the bowel cancer screening programme, I just wanted to clarify from that poster that Glenda said we hope you have seen. It's thinking about it as two different pathways and not confusing the two. So I'm going to take you through the bowel screening programme, what it involves, who's eligible. So you, if you're over 50, your family, friends, anyone who now has turned 50 since August this year will receive a fit kit, and you receive one every 2 years until you're 74. So this is a new age for our ICB area. So up until August, it was 54 and upwards, and it's now 50 onwards. Next slide, please. So the bowel cancer screening programme uses the FIT test, but it uses the FIT test in a different way. As Glenda has said, it measures a different amount of blood to the FIT kit that is used in your practice. So this is because it's population screening and it's for people without symptoms. So screening is done to try and detect a change in the bowel before cancer is even developed. And so by bringing the age range down to 50, we're hoping to prevent more cancers by finding polyps, removing them before they become cancerous. So we're looking for that hidden blood and making sure that people get those polyps removed. For people to be in the bowel cancer screening programme, they have to have a registered address with the GP, because the list is pulled by the screening hub, and the screening hub for our area is based in Surrey. So the tests come out from Surrey and they go back to Surrey. They don't come through your practice at all. So a patient will get an invitation letter and a leaflet about bowel cancer screening. Then 7 days later, they will get a box with the kit in. It's pre-labelled with their name and a barcode already on it. They follow the instructions for use, and then they put it in a return envelope and it goes back in the post. And if everything's clear, within 7 days, they get a letter saying, all good, we'll be sending you this again in 2 years' time. But if you have symptoms, you must see your GP because symptoms need investigating. So the hubs send the result or the non-responder notification to the practice. So if your practice team gets that notification, you then follow up to try and encourage people to participate in the bowel screening process. And if the result is positive, the patient is then contacted directly by the bowel screening program team based at UHBW at the BRI hospital. So if this screening test is positive, they then get immediate contact from the hospital in Bristol. Next slide, please. That's it. So this is what it looks like. So this is what arrives from the Southern Hub in Surrey through the post. It's a box with an NHS label on the front. When they open it up, it's got the prepaid envelope for sending it back, the instructions on the lid and a letter. And it goes back in the post when the patient has completed it. And I'll put the link in the chat to that website information. Next slide, please. If English isn't their first language, on the reverse of the letter, they will find instructions in the languages listed there, which tell them to contact the hub and information will be sent to them in an appropriate language. There's also videos online for all of those languages and a couple more. So we'll put those links in the chat and they'll be sent out to you afterwards as well. So the contact phone number there is a free phone number with people on the end of the phone. That's Monday to Friday, 9 to 5, to answer questions or to send out information in appropriate language if what they receive the first time isn't right for them. Next slide. So the Bowel Cancer Hub follow up non-responders. So if they haven't had a kit returned to them in Surrey within 28 days, they will send out a reminder letter automatically. If after 13 weeks they get no response at all, they then consider that episode closed and they invite them again in 2 years' time. But we know from the work that we're doing locally that if we're following up non-responders through the practice system, they might have thrown the kit away or they need reminding about where to get a kit. They can have the kit out of that sequence by phoning that 0800 number for a replacement kit. Or if in your practice you think it's better that you request the kit on the patient's behalf, or if your patient doesn't have a postal address, then you can find the information you need on Remedy on that link to take action on their behalf. There's a question in the chat, Glenda, which I'm just going to answer. Somebody's asked, is there a catch-up programme for people aged between 50 and 54 before August? No, there isn't. So if you were 50 before August, you will get your first kit when you're 52. So they had to have a start point for that. So if you're 51 now, you will get a kit next year when you're 52. Next slide, please, Glenda. So I'm going to hand over at this point to Lynn to just talk about the specifics for people with learning disabilities.
Thanks, Georgia. Yeah, so people with a learning disability are more likely to be non-responders for bowel screening, for all of the screening programs in general. So it's really important that practices are correctly coding people with a learning disability. So this can highlight that they might need a little bit more support to do their screening. So there's some really good, there's a link there, improving identification of people with a learning disability. And also when we're coding people with a learning disability, we need to be using this SNOMED code and the preferred term on the screen there, and the useful link to the Ardens webpage. We're, in BNSSG, we're under-reporting people on the learning disability register, so we need to be better at putting people on the register so they get a little bit more support. Next slide, please, Glenda. So I've come up with a few case studies of people that I've supported over the last year with their bowel screening, just so you get a little bit of a taste of how difficult it can be for some people. So there's a gentleman that I met, he had a learning disability and autism. He couldn't figure out how to get the poo sample. He thought he had to poo on the floor to get the sample. He couldn't figure out that he needed to get some container. So I demonstrated how to use the kit using a demonstration kit and some Play-Doh. And I also showed him an accessible video, which was really helpful for him. And then he called me a week later to say that he's done it, it was all fine. And then a week after that, he rang me again to say he got the results and they were all fine. So just talking through sometimes the test can be really helpful. Another person who was concerned about sending his DNA through the post because he thought it was a scam. He wasn't really sure what it was that he was receiving. So again, a simple explanation of what the test is and using easy read resources alleviated his fears a little bit about what the test is. The third case study, a person who didn't have the dexterity to collect the sample, and he was with a shared lives carer who declined to support him. So I went to the manager of the care provider and made a plan for somebody else to go and support the patient with his bowel screening test. And it was literally just the putting the wand back into the pot. It was really quite difficult for him. So we made a plan for him to get support with that. And then finally, carers unable to get a poo sample from a resident because she just flushed it. So they asked for her to be removed completely from the bowel screening programme, which I thought was a bit drastic. So I talked to those care providers and we devised a plan of how we can get that sample from that patient. So there's ways around supporting people with a learning disability to have it done. And you can contact me for support if needed. So next slide, please, Linda. So there's lots of resources on Remedy about learning disabilities and cancer screening, including how to contact me, the LD screening practitioner, and also getting advice from the Adult Learning Disability Health Service. So if you're struggling with a specific patient, you can contact the team and they can give you some advice and guidance on how to support that person. And there's also lots of easy read information on that Remedy page. So I'm handing back to Georgia.
Thank you so much, Lynn. That's great just to outline what's available in way of support for people with learning disabilities around bowel screening. So what we want you to take away from this around bowel screening and the importance of the follow-up of non-responders is that bowel cancer screening can detect cancer early when it's more treatable, and if the blood that leaks from the polyps can be detected and those polyps can be removed, then we can prevent bowel cancer from ever happening. So it's a really important screening programme and quite different to what Glenda is going on to talk about now. So I'm going to hand back to Glenda.
Thank you, Georgia. Thank you, Lynn. You're doing great work with our patients with learning disability, and we're really lucky to have you in our system. So I was going to talk a little bit about our symptomatic fit pathway, and we've touched on the difference between symptomatic fit already and the screening fit, and the importance of us all in primary care being aware of that. So the key thing is, and this is a lovely little thing from Bowel Cancer UK, some of you may notice this from your toilet roll packaging. There is lots of messaging that's going out there now, and using these sorts of approaches to alert people to their symptoms so they come and see us in primary care. So this is a list of symptoms that people may present with. Historically, if I saw somebody and I thought, do you know what, I'm really worried this person might have bowel cancer, I would send them straight off for a colonoscopy. But actually we knew we were doing colonoscopy, which isn't a terribly pleasant test, really important test, but not a terribly pleasant test. We were doing that for a lot of people, and actually they didn't need a colonoscopy. It wasn't adding anything to their care. And the introduction of fit test has really enabled us to support that sort of pathway and not send people for a colonoscopy if they don't need one, but similarly to really pick out those patients where we say, actually, we've got a positive result, we're now worried about you. The really key difference about this, like I say, so we've got that difference in terms of the level at which the test becomes positive. We've got the fact that it's screening versus symptomatic. We've got the fact that the screening tests come out in the post from the hub, and the tests we hand out in the practice. There's lots and lots of different differences there. When the fit kits initially came to us within practice in BNSSG, we were giving to patients to post back, and that changed. So we now request the test on ice as a clinician, and we then advise that, and the test goes through that way and gets sent in our normal processes from the practices. This has added some challenge on many levels in terms of patients picking up the correct kit, in terms of patients returning that kit, in terms of when we label the kit so they know that it's theirs. But the big challenge we find within practices, and a reason for lots of kits not being returned or tests not being processed properly, is that we give people the wrong pots. So we're often giving people these blue lidded pots, and the lab can't use those. So it has to be the specific kit that we've requested and left out for the patient. So this is what it looks like. It has that special envelope. It says fit pack at the top. It has information for us as a clinicians requesting the test, as well as information for the patient within it. So you can see there is a little patient information leaflet showing what they need to do, the little fit picker and a little bag, and then the GP return envelope. So the information is there on the kit. I would say it's apparent that for some of our patients that actually there are difficulties with completing this, and we are looking at sort of resourcing a video that we can give to patients to help them understand that in a non kind of leaflet type format to support that process and improve the rate of correct fit completion. There are lots of steps to make sure that this process happens really well. So if we request a fit in primary care, because we're often requesting those for patients who we historically would have referred straight for a colonoscopy, we really need to be safety netting those patients as if this was an urgent suspected cancer referral. So we counsel the patient about what we are asking them to do. We alert that onto our systems within the practice, make sure that we will follow up if they don't return the kit. They take it home, they complete it, bring it back to the practice. And I know lots of practices have got different safety netting processes around this to make sure that we do get the results back. There's also an Ardens template to support that, to prompt patients to return it. We've flagged that need sometimes for additional support. So that may be because a patient has a learning difficulty, it may be from a language perspective, and maybe that concern that's been highlighted around dexterity and encouraging people to ask for support from family members or carers to do that. The test, as you say, doesn't go in the post from the patient. It goes back to the lab with our normal path results, and then the results come back to us as clinicians to decide what the next best steps are for that patient. So this is data that was shared with us from the lab. So you can see that there are a lot of rejected fits within BNSSG. So over 300 in the last 12 months just for an incorrect container alone, and then quite a lot from a sample leaking. So these are two things that we really need to work at as a system to say, how do we make sure that we are giving people the correct kit and we're supporting them to complete it and to close it properly so they don't have to repeat it. Because I think on average, if I give somebody a fit kit, it's probably normally takes a week, 10 days for them to take it home, to do it, to drop it back in, for me to get the result. So if it's taken them a week, 10 days to do it incorrectly, drop it back in, go to the lab to reject it, then we've added that delay onto their pathway in terms of us knowing what's the best next step for them, which can have a negative impact on outcomes. But we've also added work for us within primary care, that we're having to contact the patient, we're having to provide another kit, we're having to counsel them again. So if we can do this right first time, then it is a better, smoother pathway for the patients and better for us and managing our patient demand. So this is an example from the lab that they shared. So you saw on the sort of patient information leaflet and how Georgia was saying you use the little one to rub it along the surface of the poo. So a patient obviously received the kit, looked at it and thought, I don't really want to do that. And so put a whole poo into the plastic bag with a little sampler next to it and sent it back to the lab so they could take the sample. You can see how when they're unpacking these kits, they wear really nice, thick yellow gloves. They're necessarily the funnest job. So again, you sort of look at, I think, well, how has this happened? And I've certainly changed the way I counsel patients and how they should complete these fit kits as a result of this learning and these conversations with the lab. So really good sample collection tips is making sure that when we give patients these fit kits and our process within the practice is that everybody knows about this. And this is why the beginning of this talk, we said we want the audience for this talk today to be a really broad range of people working within primary care. So we're catching everybody within our practices so that they understand the difference between screening and symptomatic fit and how we can make this all work better, because we must make sure people get the right kit the first time. This thing about click to close is really important. So I think lots of people will take the sample from the poo. So you literally take the little wand, rub it along the poo, and then just put it in, but it has to be then twisted to close it. We have spoken to the lab and they've spoken to the kit manufacturers saying, surely there must be a way that we can do this, that it doesn't require so much dexterity, that doesn't have quite such an inbuilt error rate. We've been told no. So that's where we are at the moment. These are the kits we've got. And so I now highlight to patients, remember when you do your sample that you hear it click to close. We have had conversations with practices in the past saying, well, patients who struggle with this, could they provide their poo in just a normal blue pot, and then we could move it into the fit picker at a later date, or if someone does bring in the wrong sample pot. But we've had really clear instruction from the lab that we can't do that, that the little fit picker has got a buffer in it which stabilizes the blood in the stool, and so it must go straight into that. If a patient does a sample in a blue pot and then drops it in, and there's a delay of hours, maybe overnight, a day, for us to take that sample, then that we may get a false negative for that patient. So we may then say to them, that was great, your stool sample was negative, we don't need to refer you on for an urgent suspected cancer colonoscopy, when actually the sample had just sort of expired, that the test was no longer accurate. Once it's in that fit picker, then actually it's stable for 14 days. So it has to go into there, not come from the blue pot across. So that's why the lab will reject those samples if they come in the blue potted pots, because they can't use that stool, and why we can't move that across in primary care. So this is our lab and the team there. So they are very, very busy at the lab doing this. When fit sort of came on board, we thought they would get a few hundred kits a month. They're getting sort of 4,000 or 5,000 kits a month. So primary care has really taken on board the use of fit. I have to say that's 4,000 to 5,000, not just from BNSSG. So they provide a service for Somerset as well as Glos and BSW as well. So Bath, Salisbury, Wiltshire. I mentioned earlier that in terms of those patients who we've seen who've got a symptomatic fit, we're saying we need to do this test. Accurix have some great resources that we can send. So you sort of set it up as a reminder pathway, and it sends out a prompt to them 3 days later to say, have you done this yet? This would be really good to do it, as well as providing guidance on supporting them in completing their symptomatic fit. So key messages. So the Bristol lab measures a different level of blood to the screening test. And so that's so important for us to know personally, for our family, for our friends, for our patients, that a negative bowel cancer screening test is not helpful for a symptomatic patient. And that is that big difference between 120 micrograms of blood per gram of faeces versus 10 micrograms for a symptomatic patient. So they are totally different pathways, the screening pathway and the symptomatic pathway. Screening going to the central hub, symptomatic going to our lab, normal pathology results, and it is the same fit kit, but it is a different test because it has a different threshold for positivity. So we just need to always remember that. Georgia, do you want to chat through the resources?
Thanks, Glenda. Yeah, so on the screen now you can see a video link to a video that can go in the waiting room in your practices that talks about bowel cancer symptoms and prompts people to see the GP if they have any warning signs that need to be checked. So this sort of sits well with what Glenda's just been talking about symptomatic patients being aware that they need to get checked. And there is a similar video for bowel cancer screening. It's not in this set, but I can add it to the set before it goes out. And on the last slide here, Glenda, we've got resources for continuing your knowledge and developing your learning around this. So Gateway C is a platform that's provided free by the NHS, and it's a learning platform for all of primary care. So there's a specific course around the national screening programme for bowel screening. There is also a course for cervical screening and for breast screening as well. And then there's a specific course around the FIT test and lower GI cancers. And then there's been 2 webinars done nationally on the topics that we've covered today, supporting patients with FIT for primary care clinicians, and then one for administrators as well. So if you want to further your understanding of anything around FIT, those are really reliable resources to go to. If you have queries within your practice or your PCN and you need support, please, if it's to do with learning disabilities, please get in contact with Lynn. And for anything else, please contact me. Our email addresses were in the slide at the beginning of the presentation. We've come to the end of the slides, Glenda. And there's a question. Russell's just put a question in the chat. Are the videos available as MP4 instead of YouTube? We can't add YouTube videos to your screens. So I don't know, Glenda, have you come across this question? I've not encountered it before. Russell, I'd be interested to pick that up with you and understand a bit more about the technical side of it to see if we can help address that, because I have to say I wasn't aware that you couldn't. You're welcome to come off mute if you'd like to, just to share with the others if you've got a microphone. Don't know whether Russell you can.
That's fine. We can pick it up.
Yeah, we'll try and find out a bit more about that.
But if they're being developed and an ask is for them to be shared on screens, then we need to try and make sure that that can happen. So
yes,
it doesn't sound like it's asking the impossible.
MP4 instead of YouTube. Okay, I've made a note of that. Thank you for raising it. Oh, his mic's not working. That's fine.
Hurrah for NHS IT.
Are there, we've done well in terms of time, Glenda. So I don't know if there are any other questions. People are welcome to come off mute or put a question into the chat.
We do have, we've come up, if we're ahead of time, we do have a feedback form. So that means that people have time, if they've committed until being here till past, to potentially do the feedback form. I think Cara is going to share that in the chat with everybody. So that'd be great.
There's a question from Harriet come in. Add the email address to contact for help regarding the Ardens template.
Harriet, do you want to email me about it? So I've been in contact with Ardens about the FIT template. So I can then copy you into the person that I've been talking to. So I'll put my email in the chat, just then it's there, but it will come out on the slides. But it's probably easy if you just email me directly. Cool.
Thanks, Linda. And I don't know if Chiara's there, you're able to put the
feedback
link.
Before we lose everybody.
I'm just doing that. I keep getting an error message, so I'm just working on getting that. Why is there an error message that shows? Yes, I will get that as soon as into the chat. If everybody could please collect that. Please complete that feedback form. It's really, really helpful for us, but it also allows you to receive a certificate for attending. So if you want to do that, then that's a great way to do it. But there you go. I just popped it in the chat.
Because it means that we can adapt our content and think about how we can make these sessions better. It's really kind of people to give up their time, and we are very grateful for that. But we would like it to help. People come and give up their lunch break, eat their sandwich while on Teams. Then we want to make sure the content we're delivering hits what people hoped it would do.
So I think Lynn's just put her contact details on Remedy.
Tracy said, Cara said that if you complete the feedback, then there'll be a link at the end of that. I think she said to put your email address, the certificate will be sent out to you. Boom. Thank you.
Excellent. I think Lynn's just put the link to where all her contact